Our team is myself, Dr. Vishal Kapoor, and of course, Dr. David Song. And our fellow today is Michael Sola. So if you guys can put up the slides, Michael can present the case.
Yes, so this is a 86-year-old woman with a significant past medical history of hypertension, hyperlipidemia, diabetes, as well as controlled with a controlled LDL, who's presenting with a left foot ulcer that's not being able to be healed. And so we are presenting a case of the left anterior tibial artery intervention.
So just a little more history, guys. So she basically has a non-healing ulcer of the left great toe. She had some inflow disease. It was a small ulcer in the foot. We would have showed you the picture. Unfortunately, we couldn't. And so Vishal Kapoor did this procedure earlier. What he did was he opened up the popliteal, which had a 99% stenosis. The 99% stenosis did not heal the ulcer. So therefore, now when I show you the runoff, you'll see what the story is. So if you go live on the angiogram.
Yeah, the patient had bad AVIs to begin with, had wound care, has vascular surgery and podiatry on board, referred again. So we thought we were going to improve the inflow and help the patient. But unfortunately, it didn't heal the way it is. There is some slow, delayed healing, but not complete healing whatsoever. So the idea was a discussion with PK to bring the patient back and try to revascularize the territory involved and hopefully give her a complete opportunity to heal and not have a recurrence. And like the fellow said, controlled diabetes, hypertension, hyperlipidemia. Also has a known CHF, heart function 40 to 45%, and one stent to the RCA done 3 years ago on aspirin, Plavix, and statin, and other cardiac medications.
So I guess we're having a little trouble with our AV. Is it going to go? Oh, you see the angiogram. Okay.
We're frozen. Okay.
So, okay, good. As long as so, Bhaskar, we can't see what you're seeing. So tell me if you can see the angiogram.
Yeah, we can see the angiogram.
So we got great. So we got right common femoral access, and then we did the iliac shot as we always do with good inflow. Then the left axis shows the popliteal intervention that was done right there with just a DCB. And then you see you have a robust perineal, but in the foot you only have the dorsalis pedis, and she has a dorsalis pedis ulcer. Excuse me, the great toe ulcer. Excuse me. And you see here that the AT occludes proximally, and then of course she moves a little bit. The PT is occluded. And then in the mid-segment, you can see here there's some calcification that comes through with the perineal coming. And the PT is not seen in the distal. The perineal gives rise to both the DP as well as the diseased posterior tibial. And then the foot shot, and we'll take a better one for you, will probably show you the toe. There it is, I'm sorry. This is the one, right? Oh, this is the one. There we go. This
just
one.
Different positions.
So this is and you can see that the dorsalis pedis is angiosome supplying the ulcer of the great toe, which is not healing. It's a very diseased arch, so we felt that inline flow into the dorsalis pedis will help. I mean, surgical therapy is definitely an option with her. I mean, the veins weren't great, but I mean, you could always do something. But I felt that with this kind of situation, we'll go ahead and do, and we want to demonstrate antegrade crossing of this with wire escalation technique. So because it's a live case, we went with a 7 French up and over. Like I said, we rarely do antegrade unless we're going very distal into the foot. In this case, up and over is fine. We've got the foot prep for pedal access if we need it, which I hope we won't. And so we're just going to go ahead and get into this. You can see here again, posterior tibial is very diseased. The dorsalis pedis gives all the vessels to the great toe as well as all the other toes. So you can see why this also wasn't healing. So at this stage here, what I've done is I've got an 018 Trailblazer into this. And I just want to curious what wires you try, how would you do it? I mean, what's your wire escalation strategy? For us, we have a Gladius Mongo that we have here, and we're going to try to do either intraluminal or dissection reentry, whichever one is fastest, do an IVUS, and then go ahead and do the therapy.
So, PK, what do you have there is a Mongo ES, a Gladius?
Yes, we have a Gladius Mongo 014, and then we have an 018 Trailblazer, and we're ready to move forward and do what we need to do.
So I just want to ask the panelists, when you see a reasonably favorable proximal cap like this, what is your to-go wire and your to-go support catheter? probably start with you, Dr. Shishan.
No, I don't need that.
Yeah, I mean, I think there's so many different flavors. I use a lot of 014 corner wires here, so Fielder XTA is one
Yep,
of my
it's
favorite
crossing.
wires here, and then
A lot of hibernation.
most importantly, it's just having that microcatheter, the microcatheter right close to your wire, really to control your wire,
sure there
improve
are
your tip load.
A lot of hibernation.
PK's doing this. Jay?
Yeah, so my support catheter, usually I'm using a Specs LP, and then that's from Reflow, and then I tend to use a lot of these SI
Yeah,
wires.
beautiful.
I actually like 018 because it's kind of the nice middle road between the torqueability
can I get this
and control of 014 and then the power of the 035. So I'll use the Mongo 18 here pretty routinely.
Yeah, I like to use command wires. That's my go-to wire first, but I have no issues using coronary wires as well.
So first, I choose anti-grade access to obtain a good pushability, and then using a 018 platform support catheter, I will start with command 018, and if I don't success with the command, I switch for Asahi NGP V to go by a sub-intimal approach if I fail by intraluminal approach.
Roman, let me change the question for you. You see that wire is deflecting right at that calcium spot. Would you switch wires? Would you stop there? Would you just go retrograde here just to prevent something?
Yeah, I mean, I think I agree with Eric on this one in the sense where my upfront choice would be an 014 system. I like the fielders for this very, very well. To get the catheter a little bit lower down.
Hey,
would
give me a
also
confidential.
help.
Actually, give me a Halliburton.
I think also at the same point, as far as case planning for this case, I think if there was a good amount of hibernating vessel, we would have kind of just like flown all the way down. But this chunk is kind of showing that maybe there is a true occlusive segment, and you see it even on a non-digitally subtracted image. I probably would have just gotten access in that DP and just put a wire up there and just expecting that there's a relatively good chance I was going to be going for it. I think once you get the catheter all the way down there from an antegrade portion, if you then go for a CTO wire, go with a Confianza, or just begin with that, see if you can just traverse that potentially very, very short CTO segment, maybe then you can go back with your, with your hydrophilic tip wire. And maybe not have to do anything with your retrograde axis.
Nick?
So we're waiting on that.
Yeah, I think. I think at this point I'd
I agree
probably
with you.
take a shot here because it looked like maybe that vessel was hibernating, probably patent a little longer than we saw in the initial angio. So I might take a run through the support catheter at this point and see, kind of where things are and what the occlusive segment is, which is what I think BK is actually doing right now, or at least road mapping himself. Wire choice catheter combo. I love the 018 support cath with an 014. I'm pretty simple in my wire strategy. I start with an 014 glide wire advantage married to an 018 support cath almost 90% of the time for these, and then escalate as needed. But
I think that's been my strategy. And people starting out, I think you need to get familiar with a couple of wires, understand the tactile feedback. So, PK, you're using a Halberd wire. This is the Asahi, correct?
Yeah, I mean, we've become big fans of the Asahi family of wires here. I mean, everybody, we're kind of new to adopt them. A lot of people have been way ahead of us in adopting, but I don't know, it's kind of better. That's a little better.
That's where it deflects.
It's saying recharge headset, guys, for me. We're saying recharge headset.
So, PK, let me ask you, what would your algorithm be as to, say, you try to cross this a couple of times, maybe 2-minute timer, and then after that, do you switch to retrograde axis more aggressively, or what is your recommendation?
Raman, I don't think, Dr. Sharma, I think has a great idea, but to go up front with a DP access is not something that I want to do at this stage. I think that we're going to be able to cross this. The 018 Trailblazer is really not out for an 014 teleport and maybe balloon angioplasty to track.
There's an overnight wire.
And
an overnight
would anybody
wire?
at this
Oh,
point
okay.
consider the Pierce
You want a
technique
navy cross, I can send you a navy cross.
come percutaneously and disrupt the calcium, or is it something you wait? Dr. Matthews.
Later.
We don't have an
I mean,
014.
that's certainly a very reasonable thing.
Do we have an
to
014 Halibut?
It's a much smaller target, obviously. We're going to try to, macerate that vessel with Pierce. But
All right, give me a balloon now.
I think there's a lot of other things that we can do first, and I would tend to probably go retro before I would Pierce.
So you go retrograde first. Huh?
Yeah, rather than go through a Pierce technique. But I want to see interluminal as much as possible, avoid a long subintimal segment if possible.
So when you decide to go retrograde, do you decide what is the access point so you don't jeopardize any collaterals, or is it at the ankle, above the ankle?
Yeah, I mean,
change for a contract.
my target, I mean, I use ultrasound, and I always want to identify a healthy segment to access, because I want to use the smallest access possible. In this particular case, however, the vessels are quite small, so sometimes we may even be using a minimal access technique, like just a dilator of a micropuncture or whatnot too. I don't really love sheathless as much, because if you're delivering anything through there, then that can traumatize the vessel. But I think that's a reasonable thing. One other point I was going to make was that sometimes even with the SPECS catheter, I'll go even without a wire. It's almost like using a crossbus, and it just tracks through the true lumen rather than going, because with a wire sometimes you'll end up going subintimal. But using the larger micro catheter itself too, sometimes they'll track right through the lumen itself.
So PK, you want us to go ahead and do a couple of talks while you guys work through the CTO?
Yeah, so what we're doing is, right now, we're just switching out to an 014 Halibut. We had an 018, which is fine. And now we're going to switch to a teleport. We're going to get this lower. We're going to balloon angioplasty the proximal segment. If we need to get access in the DP like Raman suggested, we will. But I think we should be okay. So once you guys go ahead, and then we'll work on the side here.
Can you tell us what's been happening?
Right, so
Give me an Astado
yeah,
30.
it's been a real struggle.
I need an Astado
So
30.
what's happened is we basically had to get distal access because from the top, the wire would not go. So we went ahead and got distal access under ultrasound guidance. We went with an 018 Astado, what was the name of that wire? The 018 Astado 30 from below. And we kept getting into the vein, believe it or not. So we had to go ahead and maneuver and then redirect the Astado 30 to find what we thought is the true lumen. So now we are in a dissected segment in the mid area, and you can see here all we have below. So we have from below, I have an 018 Trailblazer. From above, Vishal has an 014 Navicross, and you'll see the wires get really, really close. Might have to do a cart or something to figure out what's going on, but it's extremely, how can you say, calcified and a challenging lesion. So, oh boy, that does not look good. If I can get a loop, I'll be happy, but I don't. See, right there, we're crossing. Let me go to another view here.
So just for the panel, so when you see something so calcified, you guys you try the antegrade, retrograde. What point do you guys start switching to cart or something?
This goes up.
I think this is ready for cart. I mean, I've seen PK. I could see, you've got the two wires at different planes, but you've got that crossover point, like you just said, in that X. So
Yeah.
I think you could probably just bring a retro balloon right up to that X
I changed the
point.
wire. Give me one.
Take a nice your antegrade wire, something nice and soft with a good tactile feedback. Balloon it from pedal. Advance, you should be able to find your way down. I feel like that point is going to work.
So, Dr.
I mean, right here, I'm really frustrated because
Dr. Karthik, I want to ask you,
I think I'd be very.
is there any role for using EVIS and seeing where you're dissected and restarting from there? Because maybe if you started the dissection plane, you've extended it, and you try to do a cart there, it might make things worse. Any suggestions on that? At what point you start considering
Bring a
EVIS?
cart balloon from
Hold
above,
on,
please.
Flora.
Jan?
PK, can you get the wire back?
Hold on.
Definitely, yes. IVUS could be very helpful to understand what happened exactly, in which lumen we are, and so to help us to make the re-entry. Unfortunately, I don't use IVUS. I have not the ability to use IVUS in my routine practice. So in this case, I use a rendezvous technique to make the connection between both guide wires.
Wire back, please.
I think that I would just
Okay,
get a balloon from above up below, right where the two wires crisscross. I would inflate a balloon, and I think he will get in interluminal. I think that's probably going to be his plan, right, PK?
Yeah. Pull the wire back a little bit.
Yeah, I agree.
Catheter back?
It's time to cart. the one comment regarding the ultrasound, I mean, I think if you have the luxury of having
Come from
extra
below,
body
above
to
with the
do
wire.
it, that's great. Sometimes I'll actually just do IVUS.
What wire is this?
Just to
This is
see
the Saro 30.
how far am I away
long
from
wire.
the actual true
Okay,
balloon.
what
Because
do you
if you're
want,
in outer
hydrophilic?
space, when you
Little
cart
bit. I don't want it
that,
too big
then
for
you could actually end up creating a very
Give
large
me,
disruption.
give me another Gladius, please.
So Eric, would you consider two other options where you might use a laser to break the proximal cap and revisit this whole CTO, or
If I know where I'm going.
if you're okay?
That's the problem. You can laser out of the vessel.
Yeah, I think that's always the risk.
Get us a
Here you're
2.5
really
or
working
2.0 balloon,
blind.
please,
As
2.0,
soon as that
50
subminimal space
coronary
gets
balloon.
too large, you've kind of lost control of your
Yeah.
reentry capabilities, especially you're not going to be able to deliver reentry devices this far down in the tibial. So I think you do things exactly as they're
15
doing
coronary.
them sequentially. You know, you're taking a little bit
20
more
is
risk with each of these, but I think next you balloon that crossover point.
Yeah, I have a question
Yeah,
for
so
the
what
panel.
we're going to do is,
Can I get the screen?
Yep.
we're coming down with a Gladius wire from above, and then when the wires cross, we're going to card. We have a Gladius wire from below, and I think it should be good. Show me down.
Yeah.
So you're going to do a cart now, right?
Yeah, we're trying to get back in that plane, which I hope we can find it because we were pulling the wires back. Advance the wire from below, guys.
Yeah.
I just have a question for the panel. Jay, Eric, anybody who uses EVIS, you think
Right
has
there.
any role
That's
here?
good.
When you're wiring from above, you think if you have EVIS,
No, I mean, EVIS is great. Like I said, if you have somebody that can do it while, I mean, I'm not good enough to be able to wire and EVIS at the same time. So if you have a second set of hands, and because the leg is small enough, so you can actually get very nice
yeah,
visualization.
especially at this point.
You
Yeah,
have the wire?
absolutely.
Yeah.
I think it just
should have
comes
the wire
down to
now.
the availability.
Yeah, it's a great
of the-
spot for a
you know,
car
I
right
think
there.
Even
Got it?
in our
The wire?
vascular lab, we're fortunate to have them, to be there downstairs
Cool.
in the lab, but they're certainly not there in the cath lab, and they're certainly not there on Saturday morning.
So
So I have a question for the panel. We're going with a 2.0 balloon. You see the wires are crossing in that spot? And, sorry, you can see the wires are crossing right there. So I am going to
Get the
do a
wire?
2.0 balloon right at that spot. Is that okay? You think that's a good idea?
Okay, go.
Yeah, that's where I would go with it. I think right at that X point you've got there. I see you're rotating around, and they seem pretty consistent. So I'd bring balloon right up there.
And we did see
Are you-
that
what
as
the-
a cross in a different oblique, right?
Yeah.
Yeah, we did.
Yeah. We did the 2 obliques.
So for the audience, you basically have the two wires, antegrade, retrograde, and dissection planes, and you obtain multiple views and make sure you're pretty close to it, and then you inflate a balloon gently to create additional lumens and intercommunicating dissection planes, and that's the whole idea with the reverse cart and cart.
PK, did you put a sheath in the DP, or where did you put it down low? Sorry, I missed it.
No, we just have a entry catheter.
Okay.
And so I'm not able to get the balloon down any
Maybe balloon
further,
there
so we're
and
going to
then push
balloon the
up.
track here. Go up, balloon.
So Sal, I want to ask you a question. People have become quite proficient in cart and reverse cart below the knee.
Down.
Does it make a difference with regards to the outcomes? Is the patency?
Down.
Or
Down.
I'm not aware which direction you do
Come down,
cart in,
please.
It is down.
which is what the difference is, has shown.
Show me
in
down. Yeah,
difference.
David is
apologize.
planning it.
The difference is that if you don't do it, you're not going to complete the
Balloon.
case,
Wait,
and then your
here.
success rate is
Yep.
0. So I think here you're going to. There's a number of ways to facilitate reentry. The most aggressive of which is to inflate a balloon and then puncture it with a reentry device from the other direction. But
Balloon here.
you can do whatever you want and call it rendezvous or cart or
Ballooning.
double ballooning or whatever you want to call it. But I don't think there's an outcome difference.
Give me a new 2.0.
The likelihood
guys.
here is that whatever you do, you're going to destroy the artery and tear it up, and you're going to need to do something like scaffold it to get it back. And so now we have some options for that.
Let me come from down here. Come on this side. Get the balloon there, Flora.
PK, can I ask you a question? At
here, we just-
what point of your algorithm do you consider, the Pierce technique where you try to, disrupt the calcium when is it after your cart, reverse cart, or before that?
I got to be honest with you. I'm really surprised we're not crossing this because when I saw this, I thought, okay, we can definitely do this, and we're not able to cross. So I'm really, really, really surprised. Show me down below, guys. I don't know what it is. I don't know anatomically where we came out of the vessel. Everything was going really, really smooth, and then all of a sudden we're in a different plane. And I'm unable to find out. So do you have a new 2.0 balloon? Give Vishal a new 2.0 balloon and give me an 018 gold tip wire, please. A Terumo gold tip. So what we're going to do is we're going to keep working here, guys. You guys go ahead and with the next lecture, and hopefully by the time we come back, we'll be through.
Yeah, we can see on this slide. We don't see your fluoro. Can you put up the fluoro, please?
Show the angio, please, and the IVUS.
Well, we're showing you the IVUS now. We'll just cross, and I'll put up the angio. So you can see when we crossed all the way into the AT. But I want to show you how we crossed. But show the IVUS, play the IVUS for them, please. So this is from distal to proximal with the IVUS. You can see, give me a 2025, 210. You can see here that the IVUS is quite subintimal, dissected, whatever you want to call it, with vessel in pieces, as Dr. Sharma likes to say. And so what we're doing is, as we're coming back, you are clearly, very, very badly dissected in a badly occluded vessel. So we're obviously going to have to scaffold this or something. I'm probably going to do a serenader and then decide. In the meantime, I want to show you how we crossed. Can we go to the angio, guys?
You should.
So angio-wise, tell me when you see the angio.
Yeah, we can see it.
Down in the angio.
Okay, so I'm going to go down. So, I mean, tremendous struggle. I mean, we did a 2.0 balloon. There's our access. 2.0 card here, didn't work. Then we did a 3.0 card here, didn't work. Then finally was able to get the wire into a collateral. And then we went ahead to a collateral. And then from the collateral, oh boy, where are we here?
Yeah, keep going back, yeah.
From the collateral, we were able to pop into the main vessel,
One more.
check the position. Then we were able to externalize through Andre's technique, getting into that little catheter here with a little bit of manipulation. We were able to find it, and then we went in. Then we externalized, did the IVUS, and now we're going to balloon. So Vishal, pull on the wire, please. So you have to pull on this wire and this wire. That's what you have to do.
What is the wire you have externalized, PK?
We have, this is a Gladius Mongo wire, externalized. And that's enough, that's enough. Yep, that's good right there. So we're going to just balloon it to get a lumen. And then we're going to decide what we're going to do. I don't think we're going to do atherectomy, that's for sure, unless somebody suggests we should. We were planning on doing atherectomy, but in this case, we're not going to do atherectomy. We may do a serenader, so get a serenader balloon ready, guys.
Sorry. So let me ask you this, PK. What is the specific objective data you're looking for on the IVUS when you do a complicated, CT or revasc like this?
Honestly, in this case, it was an academic effort on my part because I knew what I was going to see. In this case, I just knew that it was a very, very difficult lesion, which would surprise me. But at least we got through it, and I'm glad we got through it. I can't even really size the vessel with that IVUS unless Jan or somebody can see something I can't see. So I'm just going to go ahead and balloon it with a 2025, which I know is pretty reasonable in this particular case. Let's go up here.
Start at 30, yeah.
So I'm just going to ask the panelists, would you guys agree with the strategy of IVUS balloon, or would somebody try something else different?
Yeah.
Yeah, I think it's a very reasonable strategy considering how challenging it was to cross all the different planes. I think, to hope up front that you have some atherectomy to be a part of your treatment plan is kind of dependent on what the IVUS is going to show. And you saw the loops. I mean, and if on the IVUS you see just like, you're just so completely subintimal, that's going to take that option right off the bat. So I think a serenader is a great choice here. And I think, it's going to guide the remainder of the treatment plan.
I agree with this.
It is
Eric, go ahead.
Pieces.
Eric, you wanted to say something?
No, I mean, it's an interesting paradox because, when we started doing CLTI care, we never talked about longer-term patency. It was only just to heal
2.5 serenader.
The toe. And so, if you do really long balloon inflations here, can you get this to stay open enough to heal? Potentially, probably not, looking at this. But then the alternative is how many scaffolds you put and how far down to keep it open. And is your goal keeping it open for a year, 2 years, or shorter term? So I feel like there's still this kind of question I have sometimes of, in this situation, is it better to not scaffold the whole thing and keep it open as long as needed to heal? Or like Sahil, should this be a full scaffold and stay open, for 2 years? I don't know.
Yeah,
Sal, I want to ask you a
also
question. Say,
no,
you're
so really
subintimal,
going to
you
heal?
start to, use a drug-eluting scaffold or a stent. So what is the risk of aneurysmal disease and microthrombi and making the CLTI worse?
Well, so we've seen thrombotic milieu with
bleeding,
paclitaxel.
Not yet.
Down there.
With the Limus disease, Limus agents, we haven't seen
Hold the
that.
wire, please.
So we don't see the vascular
Ah, don't worry.
toxicity and the positive remodeling that we see with
have wire for both
paclitaxel.
ends.
The short answer is we do it all the time in coronary CTOs. And
You there? I
the
can-
data there show similar primary patency as what we see
Okay, here you come.
in true
Right there,
luminal
right there.
interventions.
like-
So we would have
You're way past 30.
we have to surmise that it's similar, but we don't know. But again, I have no concerns at all. I mean, before we had stents, we're all kind of tapping on our foreheads about what to do here. But if there's a bad dissection that you can't keep open after multiple inflations, you got a scaffold.
Scaffold.
Right. I mean, you want to put a coronary DS this close to the ankle? I don't think so. But if he goes from 25 back all the way to the origin here, that's going to stay open.
Yeah,
Raman, you
that's
wanted to say
exactly what my plan is.
Just
Heal.
the-
In the last case, I'm sorry, Raman. In the last case, we did I think 5D scaffolds. In this case, also our plan is to do the scaffold. We did all this work. We want this to stay open. I wish we had a sirolimus coated balloon. I know those are in the horizon, but at this stage, we're just going to use a scaffold. And after the serenated for vessel prep.
Yeah, I just want to piggyback up on something that Eric said. This toe looks pretty gnarly. And I think for the rest of the panel too. I mean, do we all think that this toe is going to heal to the point of not needing any form of big debridement or amputation, perhaps, where really requiring a 5, 6, maybe even 7 scaffolds would be a requirement. Would just a serenation be enough just to allow the subsequent surgical treatment of this with an amp or a debridement be sufficient?
Just in the interest of time, we'll go to the next talk while PK finishes ballooning.
What we've done is we've basically put up a whole bunch of scaffolds. So this is a 2.5, as Sahil and I have always been in agreement about things like this. We're between 2.5 distal here, and then we went ahead and put a 3 3.0s above that, and now we're just going to do 2 3.5s. I just want to show you to the foot. There's a good flow to the foot with the pulse is now palpable. You'll see the bleeding from our entry site, but the pulse is now palpable. So I think we definitely want to try to keep this open. So now I'm just going to show you this overlap. I know we showed it in the where's the marker?
Right there.
There it is. Sorry, couldn't see the marker there for a second. I want to show you the overlap here, and then we'll take a picture. I know we're kind of short on time, but we got 5 minutes, I believe, till the next session. So unless I'm wrong, so we're going to get a 3.5. So we put so far 1 2.5, 3 3.0s, and now a 3.5 38 is going in for this vessel, and then proximally. We might have to go with a coronary DES. I wish we had sirolimus balloon to show how that's done, but unfortunately at this stage, we're going to have to do a coronary stent because the proximal vessel is very, very, how can you say, large. So we're going to put this 3.5 in, and I'm going to show you the overlap.
So while you're doing that, I want to ask Jan a question. So, what would be the strategy when you had this case? So you've crossed it, you've done the IVUS. How would you intervene? How would you treat this vessel? Jan, sorry. Yeah.
I think in this case, you don't understand what happened exactly. IVUS it could be
No,
very
we're
useful.
at 14. We're at 14. Come back.
But POBA is my strategy for
all the
this
way.
kind
We can
of
start from
lesion.
14.
And so,
Yeah, right there. That's the marker.
the problem, if you have some
Ready?
residual restenosis at the
Okay, good.
distal part, I am pretty reluctant to use any scaffolding. We don't have, unfortunately, the availability of bioresorbable scaffolding. And so it's a main limit of the technique is related to residual restenosis at the distal part of the Bisoni arteries.
Okay, let's get a
3.5.
So Sahil, the average length was 45 millimeters. Is there any subset which looked at...
Well, so I think Prakash holds the record, as I said. So lesions were as long as 14 and 17 was permitted, but 14 and change was in the study. And again, those performed very well. So this is probably in that sort of 20 centimeter range.
638, yeah, BRS.
So he's going from 25 back
Yeah.
to close to zero. So it's going to be a little longer than what we saw in the trial. But again, I think this is going to stay open. The other comment I'd make is that I've seen other operators in New York or at least at one time had a penchant for full metal jacketing this with coronary DES. And certainly that's a more cost-effective strategy today. But when we see them come back, those arteries are mangled. The stents are crushed and irreparably compressed. This device has a lot more resilience, even though the radial strength is comparable to that of a metallic DES. It's more elastic in its properties. So, it remains to be seen how it's going to respond, but I don't have a whole lot of concern. I think what would be, if you think about it from a health economic standpoint, more expensive than putting in 5 DRS is coming back 3 times in the first year.
True.
And so, again, from a patient perspective, one procedure is probably superior to 4. And I think here, especially if you're going to not take the toe and try to save the toe, the duration of patency that you need is going to be longer. So I think there's a value proposition there.
Sahil, can you speak to the best way to stack
Give me
or
some more
overlap
screws,
these
please.
stents? Like, what do you think?
Yeah,
is
and
the
I
right
think
way to
PK's
deploy
got it right on. I mean, so the way to do it is to
Where's
take
the second
the scaffold markers are right on the balloon marker.
Go forward.
And so as you see here, he at right about 10 centimeters on the ruler, he's got the balloon marker right adjacent to the old markers. So you can actually see that one of the markers is from the stent he's putting in, the other is from the one that's already implanted. So he's lining them up so that they're right next to one another, and that should give you a minimal overlap. Stent. In the SFA, we're taught to put a centimeter of overlap.
Another 375.
Here, you just need enough.
I don't think it is.
And again, for those of us that do coronary intervention, this is intuitive.
Yeah.
But for those that don't do coronary intervention, this is maybe a little different.
Let me go
In the coronaries, I just put in 248 DES in a big right coronary for a STEMI. Here, if we have longer scaffolds, he would have been done with this case already.
Yeah, and the other thing to remind, and he's doing a nice job of this, is always to hit that overlap right after, because that's where you get stuck trying to bring in your next device. So if you use your stent deployment balloon here, you see what's
Just
doing.
as you see here, he takes the deployment balloon, deflates it, advances it to cover the overlap.
Yeah.
Really post-dilates aggressively, and that way you can be ensured that the overlap is well apposed.
It's a really important
Yes,
point.
sure.
So we're just going to do a DSA of the proximal area. Oop. What's going to, you get a single shot.
Hold on. Oh, come
We're
on.
on single shot.
Yeah, I'm getting you off the single shot. Guys, can you? Okay, here, go.
Ready?
Uh-huh.
Oh,
Press.
boy. Anyway.
One second. Press perch. Hold on. Do this. Good. Tubing. Okay, good. That's good. Press inject.
So what are the no-go zones is deploying the stent? Do you go, is it just a centimeter above the ankle? Can you go close to the ankle?
I mean, again, 5 centimeters is what we recommend.
Above it.
5 to 10. Yeah, so you got to dip there.
Yeah.
But the rest of it looks awesome.
Rest looks really good, PK.
And you're going to be home.
Probably one more.
375?
One more 375 and we're done.
Yeah.
One more 375, guys. And I'm just going to show you a foot shot because it's getting close. I know you guys got to start the next session. So ready to inject?
Inject. Yes, here though.
So while you're looking at this picture, PK, do you always finish this with the pedal acceleration time as a baseline documentation, or that's really beautiful.
At this stage, obviously, as the Brahmin said, nobody's here to do it. We don't do it ourselves in the lab, and it's not really become mainstream here at Sinai as of yet. I know we're done because we have a palpable pulse. Through this, and Vishal has been holding pressure as we're deploying these scaffolds. So what we'll do now, just offline, is as Sahil said, we're going to post-dilate everything diligently because as for the ISU, it has to be post-dilated. So I'm going to use a 2530 balloon to post-dilate the initial part, and then I will go ahead and use a 3035 balloon and then a 340 balloon for the proximal. So it's still a little bit of work to do, But as you see, we're able to get through a very, very difficult case and more difficult than we anticipated. Thank you for your patience, and we'll see you in the next room in a few.
Thanks a lot, PK. Great case. Thank you. And thank you, panelists. Appreciate it.